All right, so we've organized today's presentation into two sections. The first will focus on the PhD training experience and the second on the MD training experience. And our collective learning objectives are to understand how different life experiences influence the ways that PhD and MD trainees navigate academic spaces, and also to learn how to apply strategies to empower marginalized trainees in research, education, and clinical environments. So when it comes to earning a PhD or an MD and being here at Stanford, we recognize that not every Stanford experience is created equally. So listening to the lived experiences of our students and trainees, your attendance today shows that you are interested in elevating your own skill sets and awareness to an end that we'll be able to share more about language that's aligned on the same meanings around marginalization and othering. So in the Padlet activity, the link is in the chat. Let's clarify what we mean when we're talking about marginalized communities. So currently we have 45 people participating synchronously. And as we gather, it's important that we're talking about the same things, right? So use the Padlet, let's co-create a definition, our working definition around marginalization, and looking forward to seeing some upvoting to help us to define what it means to be marginalized in academic spaces. And I see several ideas and definitions have been shared. Great. So feel free to use the upvoting feature so that we can see what our co-created definition for marginalization is. I see several with 3, 4 votes. This is great. Lots of folks think that groups that have been historically excluded from accessing higher education, race, ethnicity, women, sexual minorities, along with those who, because of their background, our personal identities are marginalized. Wonderful. So we want you to think of this Padlet as our virtual bulletin board. You'll have access to this Padlet indefinitely. So continue to collaborate and reflect on some of the information that's shared there. So as healthcare providers and educators, it goes without saying that we are not intentionally seeking out to harm or marginalize any of our scholars or trainees. We are, however, still responsible for closing the distance between our intent and our impact. So a framing question we'd like you to consider is, how might we be marginalizing students and trainees without even being aware that we're doing it? In a moment, Dr. Letitia Steele will walk us through some scenarios on how we may accidentally and unintentionally marginalize others, and how our comments and behavior can communicate to other people, especially our trainees who come from communities that are historically excluded or underrepresented within academia, that they are insignificant or on the peripheral and that they don't matter, least of all that they belong. As you learn more about the different flavors of marginalization, start to think about some best practices or strategies that you can use to prevent and to acknowledge and to recover from unintentional acts of marginalization and exclusion. And you'll have an opportunity to visit another Padlet at the end of this presentation, where we can bank our strategies and our best practices and our commitments and outcomes from today.
Thank you, Dr. Cohen. So as Dr. Cohen mentioned, sharing some examples from our own trainees on their experiences with marginalization. These came from a Padlet that Dr. Cohen also launched last year to ask our students about what their experiences of racism, prejudice, discrimination, and or bias have been like at Stanford. So in the first example, just to paraphrase, and you have the text there, please feel free to look through it. The first example, we're exploring assertions of being lucky that someone can check off a box for diversity, quote unquote, that other people cannot. In the second example from the top, someone mentioning that they collaborate with BIPOC individuals with BIPOC, Black, Indigenous, people of color group, and their PI does not refer to those individuals as being from the country of origin and refuses to acknowledge that. In the third example, we will see that one of our PIs, or one of our students said that their PI doesn't see color. So the negation of identity, ethnicity in this way. These are all examples of marginalization that we didn't actually ask for directly, but can contribute. In the next slide, we'll see some ways that other race-based marginalization can show up. And Jennifer, you can go ahead and click through all of these. It's going to be a bit animated. Thank you. So a couple of examples here. Failing to see races at the top in blue. People of color telling stories and having their spaces taken away or having their time taken away by non-people of color. This has actually happened to me recently. And it was a very disillusioning experience when I was called into a conversation to discuss my experiences of being a Black woman. And that conversation ended with the person talking to me about their experiences of being a non-person of color. So this happens often. This is probably one of the most common examples of marginalization that is experienced in our community. I think another one on the left in gray upper corner is using people of color as tokens, tokenism, commonly referred to. This is where others who are maybe not people of color show off their friendships with people of color. This can also be referred to as virtue signaling. So this idea that it is good, quote unquote, to have acquaintances, colleagues, friends, collaborators, partners of different identities, and doing that for the sake of being able to say that one is doing that. So these are quite common, I would say, experiences and examples of marginalization that are happening within our community right now. So when we go to the next slide, we will see a bit more about our PhD training context and where might these examples fit in. So just to contextualize relationships within our PhD biosciences student community, to really think about inclusion and belonging and to move away from marginalization, we need to understand the components in our context. So when we think about belonging, it really necessitates engaging faculty, and thank you to those of you who are here today, and a trainee-centered approach. So in this diagram, the PhD student and their faculty mentor are at the core, and around them are elements of building that relationship and that dynamic. Why is this important in our context? Our PhD trainees and their advisors have a substantive and long-term commitment. These are not short-term relationships within graduate school, but also beyond. So their connections will extend beyond the time that students are training and developing their research toward their degree. This is what I like to call together forever, for better or worse. And in addition, our faculty often sit at the top of the hierarchy in relationship to their students. So this brings in opportunities for faculty that have influence on our students' transition into and out of training. And the success of students can often depend on their mentorship of their faculty member and the status of that faculty member. So there is a lot of interconnectivity around this relationship. Our faculty and our students are tethered to each other. And so there's a lot of complicated dynamics that come along with that. And so if students are experiencing, as we have seen with our Padlet, examples of marginalization, it may not be the case that they feel like they can speak up because they see themselves in this, if I say something, I'm going to damage the relationship. My faculty advisor has all the power in this dynamic, and I may not feel empowered to ask for help or to say that I am being marginalized or express these feelings and experiences. So when we think about marginalization, it is a true threat to inclusion and belonging, which is what we want. We want to promote inclusion and belonging. How can we do things differently? In the next slide, we'll think about part of this, and we can go ahead and click through here too. And so part of how we can do things differently is to reframe our conversations as trainee-centered and have conversations that include identity. And so to get there, we have to recognize that these conversations are awkward and uncomfortable. And perhaps we have not created the trust to be able to engage in conversations about components of identity that are so deeply personal to many of us. However, we have to really move past that because really having these conversations across differences is critically important. Why? Our demographics and our landscape in higher education and arguably our country are shifting. We are becoming more of a global society, at least in research this is true, in medicine this is also true. And the shift in these demographics is leading to individuals coming into our community who are seeking this desire to be themselves, to bring their whole selves forward, as Dr. Cohen pointed out. And so people are looking for this in environments they choose to inhabit. And therefore, we must be fluid and have a fluency in how we discuss identities. Next slide. I think part of this is on us, on you in this space, and we can be leaders in this, this approach, really centering identity, informed by how we connect with our trainees, informed by how we learn about examples of marginalization and how to mitigate those. We have to feel the fear and do it anyway, and acknowledge that these conversations are moving us to action. And more compellingly, we also need to acknowledge that it's not just our Stanford bubble, as we sometimes refer to it. We have national incidents, we have international incidents, we have local incidents outside of our campus that are impacting our community on campus. And we want to be, and we need to be, acknowledging the impact of those events. And by not doing that, we risk appearing tone deaf to the current historical moment that will inform how we drive and guide these conversations. So how can we do this? We want to build trust. We want to lead with example. We want to jump in and have those conversations that are difficult. We want to acknowledge that these conversations are difficult and we're doing them anyway. We want to be available and present and open. We want to understand the identities of our trainees as they understand them. That's very important. So having conversations with our trainees about how they identify and using those identifications moving forward. And when we're doing that, we want to think about what is our role in this conversation? Are we approaching this as a supervisor? Are we approaching this as a mentor? Are we approaching this as an advisor, as a coach? Really having clarity on what our roles are when we have conversations to really bring forth belonging. And with that, I will turn it over to Dr. Shumba and Yamane to share on perspectives in MD training and educational spaces. Thank you.
Great, thanks for starting us out. And hi, everyone, excited to be here with you and starting this conversation. As we said, it's not a one-time conversation, but really longitudinal commitment to this work. And one of the things I did want to note is, although myself and Takutswa are MDs, I've also been working on trying to be more inclusive to say physician, because we do have physicians in our healthcare system that are DOs as well, although our medical school is an MD granting school. But something to be aware of is another small example that I've come across that can make people feel othered when we use MD a lot, when we actually have other physicians with us. And so I just wanted to review a couple of terms that maybe folks are familiar with or not as much, but I think are kind of a continuation of what was brought up before. So imposter syndrome is really this sense that an individual believes that they are a fraud that will soon be exposed. So everything that you have done is not out of your own skill set and like prowess, but really it's kind of an accident. Someone let you in by mistake. And this is something that's been getting a lot more press recently to, one, try and normalize it, but also that it's found more commonly in folks that are underrepresented in medicine, as well as sexual and gender minorities. And really how this has evolved, I will say, in the last couple of years, is many people saw this as like an issue that an individual felt, but really the conversation has really moved away from that and saying, it is not at the individual level, but it is the environment that people are in that makes them feel like they are an imposter. Similar with stereotype threats. So that's essentially when you have a fear that you will perpetuate a negative stereotype about your group. And so this is a great example that I try to share for folks. When you're a minority, if I do something, I am always thinking about how does that represent my race? And that is a lot of pressure to put on someone. And so I present and bring myself in certain ways, knowing that I have this pressure, particularly I think as we start to climb and get further along and feeling like you're a representative of your race. And then the minority tax is something that we see a lot. It used to be talked a lot with faculty, but really happens with our trainees as well. And I think that's incredibly important to point out, but it's essentially the extra burden of responsibilities placed on minorities in the name of diversity. And so while most faculty were focused, on our core missions of clinical care, education, research, on top of that, we also have feelings of isolation, feeling like, as I mentioned before, the representative of our race, feeling like we need to do all of the diversity work. And a lot of people love that work. I say, I love that work. I think that's one of the main things that I advance, but the problem is that those things are not historically valued when it comes to academic world and promotions and things like that. And so people love to do the work, but it takes time away from the other things that would advance their careers, and it is not recognized and valued. Next slide. And so sorry that this is a little bit small, and you'll get the slides later, but this was a great article that came out in the New England Journal of Medicine to kind of give tangible examples of how some of these things play out, specifically related to recruitment at the GME level. And so I challenge everyone to read these and really think about, have you been in experiences where you could have been continuing these efforts that might potentially have folks feel a little bit othered. So for example, as I mentioned with stereotype threat, when people really focus on like affirmative action, then people are like, am I here because I'm really here? Am I just a token? During a slideshow, I bring this up a lot, like imagery really matters. Like in libraries and the halls, we've talked about this here at Stanford too, if the pictures are all of older white men, what does that say about the environment and community that someone is coming into? And so if all the photographs are only of Black and brown folks that are doing diversity work, then people are like, but wait, what about the other work that I want to do? And then the same with imposter syndrome, how this plays out in applicants as they're watching how other people are interacting with folks during the interview day. And like, am I here just because I'm Black or brown, or not because I'm actually a wonderful candidate for this program? So just some like tangible examples to think through. And then I just wanted to give a little bit of an overview around some UME and GME work looking at representation and retention. And so I think it's really common for us to say, well, there's not many underrepresented in medicine folks, and because of that, it's because they are less qualified, and why aren't they here? But I think what's really more important is how are we thinking about, as we brought up earlier with marginalized, how have people been historically excluded, and why is the environment so toxic that they either are not coming in or they're leaving? And so that's been a lot of the conversation, I would say, as well, around in the past we used to say like a leaky pipeline, and now a lot of people are saying, why are we saying it's a leaky pipeline? People are leaving because the pipe is corrosive. So again, really trying to put it back on not the individual, but really the environment that we're creating. So in the undergraduate medical education world, kind of specifically with medical students, it has been shown that they have higher rates of stereotype threat, as we talked about a little bit earlier, and how that really can perpetuate in their performance, creating a lot of anxiety in their learning experience. There's been a lot more literature recently that URM medical students have lower grades in clerkships, but when you actually look at them, it's around a lot of the language that is used in evaluations, which then perpetuates into the MSPE, which is the medical student performance evaluation, that has shown racial disparities where Black applicants are kind of called, quote, competent, while white applicants are outstanding, and lots of these like superlatives that are used. And there's also been evidence around disparities in AOA membership. And you might say like, oh, these are all like kind of small things. These are actually the main things that impact their selection into residency. And so obviously there's been a huge push in the past couple of years to incorporate more of holistic review. But what I will say is the pushback to holistic review is people think that you are lowering standards. And what we're trying to say is that the current metrics that we are using do not indicate or correlate exactly with the future success clinically of a physician. And so we need to think about, are we using antiquated definitions of excellence, and how have those, again, metrics that we're using excluded underrepresented folks? Next slide. And so at the GME level, this is something that has been a lot of recent national discussion, which is really great now that the ACGME has a chief diversity officer, Bill McDade. And just from a numbers standpoint, as I said, we really have not made huge gains in recruitment. I always tell people right now, the hot topic is recruitment. Yes, you need critical mass, and it's important to have a lot of people, but the other thing is, it's not enough to just recruit people. You have to bring them into an environment where they will thrive. And as we're talking about, they really feel like they belong. And so we're really not making headway even in recruitment, but more the national conversation has been that there is a higher amount of residents that withdraw or dismissed from residency programs. And so the ACGME is actually currently starting to investigate this more, because there hasn't been a lot of data into what are the causes. But again, a lot of it is postulated around pervasive discrimination. People are aware of the quote of like the soft bigotry of lower expectations, that underrepresented trainees have harsher consequences. And so this is something that's actively being looked at a national level. Next slide. And so I just wanted to, this is a great article for folks that I would encourage you to read, but this is one of the quotes that I think was really impactful. So academic medicine perpetuates the myth that racially marginalized qualified candidates are inherently scarce, all the while participating directly in manufacturing the conditions that make our field inhospitable to marginalized candidates. And so on the right side of this is just a tweet from one of my pediatric colleagues, is just giving an example of, since grade school, you're told you won't make it, you won't make it, you won't make it. And then we kind of look around to the faculty and say, like, where is everyone? And so I think we really have to challenge ourselves that many times we're pathologizing race, like, why are there not underrepresented folks? What is inherently wrong with them? They're not there, while not actually examining the structures that have led to their historical exclusion. Next slide. And so this was an article that came out a couple of years ago, looking specifically at the challenges that residents and fellows encounter. A lot more work has been done at the UME level in the past, so we in the GME world are starting to catch up. But this one essentially it was a qualitative study with experiences of underrepresented GME trainees. And the three key themes that came out of that is really daily bias and microaggressions, having to deal with the minority tax, which I had mentioned previously, and then challenges negotiating professional and personal identity. And so when you think about these as a trainee, what ideally a trainee just wants to focus on being a trainee. But if you think about having to then deal with all of these elements on a daily basis, it adds a lot of cognitive and emotional burden. And so with this, though, I'm going to take Takuzwa to take over and give us some strategies around these specific issues.
Okay, thank you, Dr. Yamani. And I'd also like to thank Dr. Carmen Powell. She's not here today, but she was very instrumental in creating the rest of these slides. So as we've talked about, there's just a lot of things that factor into the cognitive load and everything else that underrepresented in medicine minorities have to interact with and also navigate as they try to go through their careers. So thinking about microaggressions and bias. So this is something that happens on multiple levels. So again, training is very, very difficult, very, emotionally and physically taxing, but for a lot of minorities, they have to deal with microaggressions and bias. So from leadership or supervisors. So some of the comments about, the tokenism, you are here because we need to, not necessarily explicitly said, but because we need to fill certain diversity metrics. Peers also thinking that maybe you're less qualified, but you somehow made it in because of those considerations. Ancillary staff, we're not used to seeing people who look like you, so have many assumptions about how you got to the role of the position that you're in. And then patients and families who, again, depending on what's happening, within the world or around us at the time, can have different preconceptions. So an example would be, 9/11, a lot of the bias against Middle Eastern providers or trainees, and more recently, just thinking about coronavirus and a lot of the anti-Asian rhetoric that we've had as well. So all of these things do factor in and make what intrinsically is a very difficult profession to adjust to and adapt to more challenging for people who are minoritized in various ways. So thinking about how we can make this better. So it's really, really difficult, to be able to see what our points of unawareness, or other people call them blind spots, are. So checking our own biases. Many people have done the implicit association test, which can give some surprising findings as far as what our leanings to for various things. It could be age, it could be weight, race, a lot of these things. So you're not aware of what your limitations are until you investigate them. Another thing that we can do as faculty that's really important is being upstanders and bystanders. So naming and responding. So if you have a patient who says something that is not necessarily appropriate, then that is a good time for you to really role model for the rest of your trainees, and also to support the trainee that's been marginalized and saying, this is not what we value as a community at Stanford, and maybe you can reevaluate what your thoughts are about this particular thing. So providing support and also providing a good example. Another thing that's really important is that confidential reporting. So many times things happen and people just, have different ways of coping with them, but really being open about the resources that we have as far as reporting and getting access to additional remedies to try and make it a more inclusive environment. So a really good quote is from Stephanie Cortez. So this was from an experience that she had where a doctor introduced her to a patient as, "This is Stephanie, she's Mexican, illegal Mexican." So all of the connotations about illegal migration and what exactly would that entail? What does that make her feel in terms of her position in the team and as a caregiver for that patient? So this would be a really good point to, step into and try to support her so she does not feel marginalized. Next slide, please. So there's a lot of talk about kind of, the hidden curriculum and the importance of assimilating. So there have been some trainees who said, "Oh, I felt like I had to learn how to play golf," or other things like that. So I'd have additional things to talk about with my team and feel a better sense of belonging. But that is really important for us as faculty to really factor in. So what are some of these previous experiences that we are putting into our roles, and how universal are they, and that they really making it so that some people feel marginalized or that they can't really participate as a part of the team. So examples would be, appearance. So there's a lot of talk about, afros, dreadlocks, things like that, different things that some people feel they're not allowed to really express their identity when they show up in clinic. Speaking, so you can tell that I have a Zimbabwean British accent. So I've had many patients, many people who've tried to tell me how to pronounce words, even up to this level. So again, that's another thing that many people might feel they don't quite belong because they're not fitting that heteronormative description of what a doctor should be. Name pronunciation, I always think that it's better to try. So, many names are pretty phonetic. So if you do give it your best shot and say, "Please correct me if I'm wrong," that's another way to create a more inclusive environment and team. There's quite a bit of social isolation, and then just, with the minority tax, it's hard to find professional mentorship if you're underrepresented in medicine. So what can we do? So definitely approaching everything from the lens of cultural humility. You don't know what you don't know, but you can always learn. So that's a really important, very open way of coming into these interactions. Sharing networks and trying to create social connections. So we'll talk a little bit about LEAD and some of the other interventions that have been happening at Stanford to facilitate that. And then also making a habit to just check in and ask, what so we're doing a better job with, pronouns and things like that, but just making sure that your trainees feel included and valued as a part of the team. And sometimes it's just as simple as asking the question and getting some of that information from them directly. Next slide, please. So just another thing to think about is the minority tax. So one way that I think about it is, in training to be medical professions, we learn various things, how to read a metabolic panel, a blood count. All of that is considered to be a basic, baseline level for what we should know as providers. But I feel like a lot of the DEI work we've been doing and being able to support some of our more marginalized populations is also something really relevant that all of us should know as physicians. So thinking about the minority tax, there are some communities, some individuals who've traditionally been asked to be representatives and ambassadors to fix the problem that's happening in academic medicine. I think it should be a collective effort that we're all involved in, and that can definitely help to make it so a lot of the Black and Brown people are less overly taxed, and also sexual and gender minorities as well, with making sure we have an inclusive environment. It should be a task that we're all invested in and all working towards making a more inclusive environment. So with the minority tax, some people are always tasked with taking on additional activities and roles, just to try to nudge that button a little bit towards a more inclusive environment. So again, one thing that's really important, to not really assume that everybody wants to be involved in diversity work. There is a difference from the lived experience and then also just wanting to really engage and change some of those structural and existing biases that are there. So just because someone does experience some of these stereotypes and other issues does not mean that they want to be involved in educating and changing, the landscape around that. Also, a lot of times, if there is something coming up, we can say, oh, this trainee would be really well positioned to present this talk. But again, that's producing a lot of pressure. The hierarchical thing, if it's an attending that's asking you to do something, then you feel compelled to say yes. But this is a very emotional task for many minorities. So again, they might not be the best served to do this role. So being very mindful of that in terms of what we ask and what we expect of our trainees. Next slide, please. Okay, so hopefully this poll will work, but I'm hoping that you can just put in what you feel are your most salient identities. So it could be various things. It could be your role as a parent. It could be your gender. It could be your race. So if you can respond, I'm sorry, my name makes it much harder, much more taxing to do this, but you can text to Kudzwa Shum 034 to 22333, and then you can put in some of those identities. And then at the end, we'll be able to share that poll EV just to see how everyone identifies. But that's going to be kind of an important part of thinking about intersectionality, how we all bring different identities to our work, to our lives in general, and how that can affect a lot of how we interact. So if you can just get those details, and we'll be able to share the poll at the end, that will be super. Okay, great. So as you're doing that, hopefully you got access to everything, and it's also in the chat. So just thinking about intersectionality. So it's all of our overlapping and intersecting identities. So many different factors. So, I can identify as a relatively young African female, and I'm from Zimbabwe. So again, that's something to consider too with our international medical students and grad students as well. So all of these things just factor into how I navigate the world, what other things I'm thinking about. Could it be my visa that's almost ready to expire, or I'm not sure if I'll be able to find a job because I don't have the appropriate visa status. So all of these things do have different salience depending on what state you are in your training, what else is going on. And these all combine to create a very unique kind of landscape for everyone. And that can give us, privilege in some settings and also make us prone for discrimination in others. Next slide, please. Right. Another thing just to think about is it's really important to have representation. So for many, thinking about that pipeline problem, recruitment and retention, for many people, if you can't really see someone who looks like you, so Dr. Imani had described, I think, how if you go into interview and the panel or the wall is full of, white male physicians who've been instrumental to that school's development, it does give you a sense of, do I belong here? Is this my place? There are many disparities though throughout, even from med school level going all the way up. We know that it is more difficult for promotions to happen for underrepresented in medicine. Stanford is doing a good job at trying to stabilize compensation, but again, there are some disparities in other places. Some level of social isolation that goes back to that homophily, where when people see something that they have in common with you, it is easier to just interact and create more social networks as a result of that. But some people can definitely be excluded from that. The minority tax that we talked about, and then that paucity of mentors and other minorities in leadership or going through this journey with you that can provide some of that social bulwark to just keep you going through what is, essentially a very difficult training process. Next slide, please. Right, so one of the things that I'm very excited about and Dr. Imani is involved in is the leadership education in advancing diversity. So it's the fifth year that we've had this going on. So we have mentors that we select all across GME. We also have some scholars. It's a 10-year long longitudinal curriculum culminating in a presentation, the Diversity and Inclusion Forum, where we get to share a lot of our insights and a workshop that we've developed with the wider Stanford community. So this has been a really pivotal experience for many of our GME trainees, where they've been able to find a sense of belonging, also find a lot of the vocabulary that they need to express what they're experiencing in medicine. So a really good quote is from one of our previous scholars who says, to paraphrase, she always felt that she had something to say, but didn't think that she should be so loud. The mentors really helped her to elevate her voice and told her her ideas mattered as much as everyone else. Fostered a sense of belonging and made her feel that she did have a home and a place among these accomplished doctors and scholars. And now she can see herself tapping into leadership, and that's exhilarating. So a very transformative experience and a very pivotal stage for many of our trainees that hopefully will lead to us kind of, nudging it a little bit as far as creating more diverse and inclusive environments. Next slide, please. So last thing before we kind of open it up to more general discussion. So what does belonging mean to you? So we're going to share some of those identities that you shared, but you are only free when you realize you belong no place, you belong every place, no place at all. The price is high, the reward is great. So this is a wonderful quote from Maya Angelou. One thing that I would have us reflect on though, is that there are some people who never have to think about this. So for many marginalized communities, individuals, this is something you have to grapple with all the time. Do you belong? Are you good enough? So just thinking about what belonging means to you, and also how you can empower those people who do have to think about that all the time and have it as an additional cognitive load in what's already a very difficult process in the MD and PhD fields. So I don't know if we have time to look at the video, but I think we're a little bit over.
Long.
So, okay, great. So let's move on to the next slide, please. We'll share the slides so you can review at your leisure. Okay, great. So if you can scan this QR code. So I know we've talked about a lot, covered a lot, but just something to get you thinking a little bit. What strategies will you use in your space? So there's many different areas. So, in medicine and research, etc. Just thinking about what we've discussed so far and how that might impact how you interact with your trainees who are underrepresented or don't really have that sense of belonging as a default. So please go ahead and log in, and we'll also share the findings. I'm just going to look up the poll everywhere and share that as well. Next slide, please. And we'll turn it over to Magali and the rest of the team as we take questions from our presentation.